Hypertension is high blood pressure. It can be classified by its cause. Most hypertension, we don't know why it's caused. That's 90% of the cases. And we call it essential or idiopathic or primary hypertension. In only 10% of the cases do we know what causes it. And we call that secondary hypertension because it is secondary to another disease. In 2003, a big report was put out, the 7th report to the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure. And in that report, major changes were made in what we call hypertension and what we know about hypertension. According to that report, high diastolic blood pressure is no longer considered to be more dangerous than high systolic blood pressure. Studies have shown that elevated systolic blood pressure is strongly associated with heart failure, stroke, and renal failure. For those older than age 50, systolic blood pressure is a more important risk factor for cardiovascular disease than diastolic blood pressure. Pre-hypertensive blood pressures are no longer considered high normal and require lifestyle modifications to prevent cardiovascular disease. So what we used to think of as just high normal, no, we're saying you need to change your lifestyle with these. Thiazide-type diuretics should be the initial drug therapy for most patients with hypertension, and that's either using the thiazides alone or combining them with another drug. Previous labels of mild, moderate, and severe have been dropped. Now, there are several cultural considerations that have come out in this report. Beta blockers and ACE inhibitors have been found to be more effective in white patients than African American patients, whereas calcium channel blockers and diuretics have been shown to be more effective in African American patients than in white patients. Now, if you remember, blood pressure is the product of cardiac output and systemic vascular resistance. The cardiac output piece is a combination of the heart rate, the contractility, which is the strength of the contraction of the heart, and also the volume of what's in the blood vessels. You can't put out a whole lot if you don't have much in there. Systemic vascular resistance is a factor of how much are the vessels constricted and how much are they dilated. So, if someone has hypertension, we can address it by decreasing the heart rate, decreasing the contractility, decreasing the volume, or increasing the vasodilation. And if we look at this chart, which is figure 24.1 from your text, you can see it better if you look in your textbook. That's basically what this figure is talking about. It's saying the cardiac factors and the circulating volume, all of that is part of cardiac output. And then that bottom line there, that's talking about all the things that affect the systemic vascular resistance. And this figure has also done a nice job of showing you where the different drugs act in treating hypertension. Adrenergic drugs. Some of these act centrally on the brain, and some of them act peripherally on the heart and the blood vessels. Of the ones that act centrally, we're focusing on clonidine for this class. And these drugs in general, plus clonidine specifically, block the stimuli to and from the brain, so we get a lower heart rate and lower contractility. That's going to work towards lower cardiac output, and a higher vasodilation. So we get increased, a decreased systemic vascular resistance. So these particular drugs work on both parts of the math problem here. And so do the ones that act peripherally. Remember, these act on the heart and the blood vessels, they decrease the peripheral vascular resistance, and they increase urinary flow. That's going to lead towards increased diuresis, so you're lowering the volume within the vasculature. Beta blockers reduce blood pressure by reducing the heart rate. They reduce the secretion of renin, which is part of that whole angiotensin, aldosterone cycle, which would increase blood pressure. Long-term use can cause reduced peripheral vascular resistance, and propranolol and atenolol are the two drugs within this category that we're going to look at. Angiotensin-converting enzyme inhibitors, also called ACE inhibitors, is a large group of safe and effective drugs. They are often the first-line drugs for heart failure and hypertension. They can also be combined with thiazide diuretics or calcium channel blockers. They inhibit the angiotensin-converting enzyme, which is responsible for converting the angiotensin 1 into angiotensin 2. Angiotensin 2 is a potent vasoconstrictor and causes aldosterone secretion from the adrenals. And it's the aldosterone that stimulates water and sodium resorption that would increase the volume that's circulating in the vasculature, and that would increase the blood pressure. So the ACE inhibitors block this process, resulting in a decreased systemic vascular resistance and vasodilation. Well, it also decreases the cardiac output because it decreases the circulating volume. We use ACE inhibitors for hypertension, heart failure. It helps to protect the heart after having a heart attack. And it also protects the kidneys for people with diabetes. So it is the drug of choice for people with hypertension and heart failure together. And it's also the drug of choice for people who are hypertensive and have diabetes. The ACE inhibitor that we're going to look at, that you're responsible for, is enalapril. There are lots of adverse effects, as they are with most drugs. The ones that seem to be different here is there's a dry, non-productive cough, which will go away when you stop taking the drug. Angioedema is rare, but it's potentially fatal. You need to know what angioedema is. And it's also first dose hypotensive. I want you to figure out what that is, too. Calcium channel blockers. They cause smooth muscle relaxation by blocking the binding of calcium to its receptors, which is going to cause vasodilation, right? So we'll have a decreased systemic vascular resistance. The drugs here in this class, verapamil and nifedipine. Why do we use them? Well, angina, hypertension, dysrhythmias. You heard about this drug with all the other groups, this classification with the other groups for today's class, so maybe you should know this section. That's a hint. They're also used for migraine headaches and Raynaud's disease. It can cause problems with hypotension, palpitations, tachycardia, constipation, nausea, rash, flushing, peripheral edema, dermatitis.